Good evening, everyone. Today we will start with the cardiology class of angina and non-ST elevation MI. So, hopefully, audio and video is clear to you. Hmm. All right. Today's topic is unstable angina and non-ST elevation MI. They have almost the similar causes and almost the same management. Almost the same management. So if we will start with the clinical feature of these syndromes, so the clinical feature are exactly same as what we have discussed in the ST elevation MI, but here the symptom the duration is slightly less. For example, if we talk about the chest pain, the features will be the same. The chest pain duration in cases of the angina is 20 minutes, and for non-escalation MI it is usually 30 minutes. So chest pain duration is a slightly shorter duration. Rest of the symptoms will be the same. Now, investigation wise, the first investigation is of course ECG. And here the ECG will show us because it is a subendocardial injury. So the ECG changes will be of ST depression and T wave inversion. So the ST depression and T wave inversion will be there. And the cutoff for ST depression is it should be more than 0.5 millimeters, and T wave inversion for more than 2 mm. These are suggestive of which guidelines to be followed. We usually followed the American Heart Association guidelines for the management and for these ischemic heart diseases. Now, suppose a patient ECG is normal. So this is a protocol for you. If a patient has a anginal pain but ECG is normal, so you repeat the ECG, repeat the ECG 20 to 30 minutes. And if it is still normal ECG, then what you have to do, if normal, still after the 20 to 30 minutes, then you ask the patient, the technician to do a lead V7 to V9 and right sided leads. Leads ECG should be done because these values of V7 to V9 they are not detectable. The posterior wall is not detectable in the standard lead and on the right side. So whenever the ECG is normal, repeat it after 20 to 30 minutes. If it is still normal, then go for these ECG lead placement. And remember the value of ST depression and T wave inversion for diagnosis of the unstable angina or non-ST elevation MI. While the second test which we do is the number 2 test is the marker, and that is a troponin. Troponin marker is being done. So last time we have discussed about the troponin and the highly sensitive troponin assays. They detect their sensitivity is very high, so they detect the myocardial infarction. So we usually go for this highly sensitive troponin, and the value to be positive is it should be more than 99th percentile of upper normal limit, and that will make it a diagnosis of non-ST elevation MI. And if it is below this range, then it will be a case of a unstable angina. Unstable angina. Now, what are the before the management? The most important part of this today's discussion is the management. So before the management, let's see the assessment score or risk assessment score in cases of non-ST elevation MI and unstable angina. So these are the risk assessments. Risk assessment scores. And they are developed for the non-ST elevation MI patients. So the important risk assessment score is the number one score. We use a TIMI score. TIMI score. Though the name is thrombolytic thrombolysis in MI, but this score is for non-ST elevation MI, and we take 4 clinical parameters, and more the points, more will be the poor prognosis or high risk of these patients. So the TIMI score, it include age more than 65 years, then more than 3 coronary artery disease risk factors. Number third, patient is a known case of CAD with more than 50% stenosis. Fourth one, if patient is having more than equal to 2 angina episodes or chest pain in 24 hours, angina pain in 24 hours, then ST more than 0.5 mm, ST depression, increase cardiac markers, and prior aspirin use. Prior aspirin use. So these are the 7 TIMI score markers. 7. While more complicated, you have to just remember the name of that scoring system, and that is a Grace score. Grace score is a global registry in acute coronary event for mortality, for the mortality. So these are for the mortality. While there is one more score, and that is for a long-term prognosis. Long-term prognosis after the discharge of the patient, that is known as a TIMI stable ischemic CAD risk score. The first two score are for short-term risk or short-term mortality, while number third is for a long-term prognosis. For long-term prognosis. So what are the components of this TIMI stable ischemic CAD risk score? So the points which are included here are CHF, presence of the CHF, hypertension, age more than 75 years, presence of diabetes mellitus, prior stroke, patient has a prior bypass surgery, patient has peripheral artery disease, PAD is a peripheral artery disease, or patient is a current smoker, or EGFR less than 60. Less than 60. So these are the points or the parameters which will be used for a long-term prognosis in cases of non-ST elevation MI patients. Now, moving on to the most important section is the management of these patients. So we can divide the management into different components. Those will be anti-ischemic therapy, that will be antiplatelet therapy, then antithrombotic therapy, and PCI, and their mechanism as well as their clinical effect study wise. So in the management, which is the most important part here, management. So the first is the anti-ischemic treatment. Anti-ischemic treatment, the mechanism of action, and clinical effects. Clinical effects. Or we can add here some important comments in the clinical effect for these anti-ischemic agent. Number one is nitrate. Nitrate. So how does the nitrate work in cases of the non-escalation MI or unstable angina? So the mechanism here will be nitrate. It increases the coronary blood flow. Coronary blood flow. As well as it reduces the preload. It is a venodilator agent. So when it is reducing the preload of the patient, so what it is doing, it is decreasing the oxygen demand. It also have a mild reduction in afterload. So if a mild reduction in the afterload is seen, so how it will help in the non-escalation MI? It will decrease a ventricle wall stress. Ventricle wall stress during the contraction. As well as nitrate have seen as a mild antiplatelet action also. Mild antiplatelet action is there. So these are the four mechanisms by which the nitrate work. So how the nitrate is given, we have discussed that also in the previous class, so we can revise it once again. So the nitrate is given as, you can give it a sublingual dinitrate dose, 5 milligrams at 5 minutes interval, and maximum we can give 3 doses. And if the patient is not getting the relief even after the sublingual dinitrate, other option is you can give a nitroglycerin dose, sublingual 0.3 to 0.6 milligram. That is a second option. So we start the patient on intravenous nitroglycerin. Nitroglycerin we can give, and the dose, starting dose is 5 to 10 micrograms per minute, and it can be titrated with a maximum titration dose of 200 microgram per minute. And also know that if you're treating a patient with the intravenous nitroglycerin and dose is on a higher side, and patient says ki okay, my chest pain is all right, do not stop it abruptly. It should be, again, if you are stopping the NTG, it should be with a titration reduction of the dose rather than abrupt stoppage, because it can cause a rebound ischemia. Now, the important contraindication where it should not be given, it is a systolic BP of less than 90, it should not be given. And if right ventricle MI is there, it should not be given, because right ventricle MI needs preload, so it will reduce the preload there. Now, what is the clinical effect in terms of mortality? Remember, whatever drug, any new drug which have come for the angina or any MI, the study says ki it should decrease the mortality. But unfortunately, nitrate have no mortality benefit. There is no mortality benefit with the nitrate. Now, come to the number 2, anti-ischemic therapy. Number 2, it is beta blocker. Beta blocker. Mechanism of action, beta blocker by reducing the oxygen demand of the heart. Oxygen demand of the heart. And what are the clinical effects seen with this beta blocker? The clinical effects are very important. It decreases the mortality, short-term mortality. Yes, very important point. It decreases the chances of reinfarction. It decreases ventricle arrhythmias. Ventricle arrhythmias. So, what is the agent given? Agent given is we can give oral metoprolol. Oral metoprolol can be given here. The dose can be 50 to 100 milligram BD. It can be given. Or if oral metoprolol is not able to take care of the tachycardia, then it can be followed. We can give intravenous metoprolol 5 milligram, 3 doses can be given. Why? The contraindications. Contraindications of the beta blocker are the contraindications of AV block, patient having a active bronchospasm, it should not be given, as well as it should not be given in acute and severe heart failure. Should not be given. So these are the contraindications of beta blocker. So what should be done if the beta blocker are contraindicated, especially if a patient has an active bronchial asthma? In that case, calcium channel blocker will be useful. So the number 3rd agent as anti-ischemic therapy is calcium channel blockers. Number 3rd. These are non-DHP agents. Non-DHP. And main indication of giving the CCB is when beta blockers are contraindicated. When beta blockers are contraindicated, especially the bronchospasm. But also the contraindication should not be present for these CCBs, and contraindications is again AV block means PR interval more than 0.24 seconds, or AV blocks, any type of the AV blocks and PR interval of more than 0.24, it should not be given. And how does they work? They have a vasodilator effect. They decrease the contractility, they decrease the oxygen demand. Now what is the effect? Effect is no benefit. on mortality or reinfection. So why we are giving when they have no mortality benefit or reinfection? We are giving them as anti-ischemic therapy so that the patient symptom is reduced, patient anginal symptom is reduced. So they are given mainly as a symptomatic therapy. Now the number fourth agent as anti-ischemic agent, it has got a analgesic effect. Analgesic effect, sympatholytic also, that is morphine. Morphine. So morphine, when it should be given, the indication of giving the morphine in a elevation MI is if pain persist. If pain persists despite nitrate and beta blockers. Then the role of the morphine. The dose of the morphine here will be, it is given as 1 to 5 milligrams every 5 to 30 minutes. Every 5 to 30 minutes. As such, morphine does not have a long-term benefit of the mortality. It is just for symptomatic therapy. So it is symptomatic therapy only. And very important point here, take home message is morphine slow down the intestine. So it slows intestinal absorption of oral antiplatelets. Oral antiplatelet. So this should be kept in mind that the morphine can have an effect on the intestinal absorption of oral antiplatelet agent. So these are the four agents which we call as anti-ischemic therapy. Now come to the number two heading of the treatment, and that is a antiplatelet treatment. Number two, antiplatelets. Treatment. Same thing. Mechanism of action and clinical effect. Clinical effect. As we know that thrombus is a platelet rich thrombus, so antiplatelets are the mainstay of treatment here, out of which the most important antiplatelet is number one, aspirin. Aspirin. The loading dose. The loading dose of the aspirin is 325 milligrams, and it should be crushed in the mouth, non-entry coated. And the maintenance dose after the loading dose, we give a maintenance dose of 75 milligram OD once a day. Now, what is the contraindication? Contraindication is allergy. It should not be given, as well as if it is a active bleeding, like a peptic ulcer. And if patient is a known case of some platelet disorder, it should not be avoided. So platelet disorder. Now what is the mechanism? Mechanism of action is, it is a inhibitor of cyclooxygenase. That is COX. And if a cyclooxygenase is inhibited, there will be inhibition of synthesis and release of thromboxane A2. So the platelet aggregation and adhesion will be inhibited. Now, what is the clinical effect? Clinical effect of aspirin is it reduces the complication of MI. So it decreases adverse clinical events. It can be death, or it can be a conversion into from angina into MI, CHF. So it decreases those adverse clinical events, as well as it decreases recurrent ischemic events. So it decreases the recurrence also. Now, number 2 is clopidogrel. Clopidogrel. So how the clopidogrel has to be given? Clopidogrel has to be given as a loading dose of 300 to 600 milligrams. So loading dose 600 milligram when we are planning for a PCI. What will be the indication of PCI, that we will be discussing later on. So this is a loading dose, and it is followed by a 75 milligram OD dose. OD dose. Now, what is the mechanism of the action? Mechanism of the action is it inhibits ADP binding to surface of platelets. Platelet. Important one is the P2Y12 receptor. This is the mechanism of the action. And what is the clinical effect? Clinical effect is alone it is not having such a good clinical. It is in addition with aspirin. When it is added with the aspirin, it reduces the death. It reduces the myocardial infarction. It reduces the chances of stroke. But when it is added with aspirin, so it should be given with the aspirin. Now come to the number 3rd agent with the same mechanism of the action, and that is prasugrel. This is the 3rd agent in the list, antiplatelet agent. Important points on prasugrel is a loading dose of 60 milligrams is the loading dose, followed by 10 milligram once a day. So where is the best use of prasugrel in contrast to or in comparison with the clopidogrel? So the best use it is in age less than 75, because more than 75 years of age it should be avoided, because it can cause cerebrovascular accidents. In those patients in whom PCI is planned, that is the best use. Contraindication is this is your NEET SS question also, prior stroke or transient ischemic attack. If there is a history, do not give prasugrel. What is the benefit? Benefit is it decreases a cardiovascular mortality, myocardial infarction, conversion into a myocardial infarction, and decrease the stroke. Same comparability as clopidogrel. So these are the same benefit which we can see. But there is one more additional benefit which is seen here, is it is more beneficial in reducing, it has been seen, it reduces a stent thrombosis compared with clopidogrel. According to the study wise. So therefore it is preferred over the clopidogrel if we are planning for a stent placement, because it reduces the stent thrombosis. Now Number fourth agent, it is a ADP blocker. ADP blocker. This is now is one of the or we can say is a preferred agent along with the aspirin. Given in a loading dose of 180 milligram followed by 90 milligram twice a day. So this is now considered as a preferred agent. Cost factor is one thing, but preferred agent along with the aspirin. Again, it decreases all these parameters, like it decreases the mortality, MI, and stroke. It decreases the mortality, MI, and stroke. Now, coming to the fifth antiplatelet agent with the mechanism of action as number 5. This agent were earlier used very frequently, and these inhibit the platelet aggregation. By inhibiting glycoprotein 2B3A. Glycoprotein 2B3A agents. So these agents they were used very frequently before the new antiplatelet agents and the antithrombotic agents. So these include the abciximab or iptifabetide or tyrofibin. These are the agents. So what is the role of these agents? The role of these agents is these agents are given for patients undergoing PCI procedure. Because during the PCI there is a chances of thrombus rupture, so we give this additional agent which prevent the platelet aggregation. And if patient is not going for the PCI, these are not recommended. So these are recommended for patient undergoing the PCI. If PCI not planned, so these agents not used. These agents are not used. So what is the clinical benefit or clinical effect of these agents? These agents are useful for the PCI in high risk. There is a benefit. Agents, then dual antiplatelet agent, PCI in a high risk patient. What is a high risk patient? The high risk patient is a patient who got diabetes mellitus or very high level of troponins. So in those very high risk patients, they are beneficial. They have more benefit than the side effect. Now the number 6. This is a relatively new agent, and that is a intravenous P2Y12 inhibitor. So what is the name? Name is Cangrelor. Cangrelor. The indication of this agent is it is given for those patients which is not treated with oral P2Y2 inhibitors and being given glycoprotein 2B3A inhibitors. So those patients, because of any reason, they are not being treated with the oral agents and they are not being given GP2B3A inhibitors. In that, we can use this intravenous agent when it is available, and it decreases the three events: decrease the death, decrease the MI, and decrease the stent thrombosis. Decrease the stent thrombosis. So this is the relatively new agent. Now coming to the number third treatment option as a group, and that is number third, anticoagulation. Anticoagulants or antithrombotic. Antithrombotic. Mechanism of action and clinical effect. Clinical effect. So the number one agent is in developing countries still unfractionated heparin. Inhibit the coagulation factors, and this unfractionated heparin has shown to reduce the mortality. Now, for how long this is given? This is given for 48 hours or till PCI done. During that time it is given. It is not given for a very long term. So 60 units per kg is the bolus, followed by infusion of 12 units per kg per hour. Number two, that is again mechanism is inhibit coagulation factors. Again decreases the mortality. That is a low molecular weight heparin, and the best low molecular weight heparin which has proved to be beneficial and most commonly used is enoxaparin. And till what time it should be given? It is given till the patient is hospitalized or PCI done. So it can be given till the hospitalization depending on the patient ambulation. So the dose is 1 milligram per kg body weight twice a day, BD, subcutaneously, low molecular weight heparin. So these days we prefer a low molecular weight heparin instead of a unfractionated heparin. Number third is a direct thrombin inhibitor. So this is the agent which is given, and this is considered to be alternative to glycoprotein 2B3 inhibitor. Therefore, the role of glycoprotein 2B3 inhibitor is going down. So when the patient is undergoing PCI procedure. So this agent is helpful, and it has been shown to again decrease the mortality in cases of angina or non-escalation MI patients. So these are the three important agents, the anticoagulant or the antithrombotic agents, which are used. Now come to the PCI or a percutaneous coronary intervention. The fourth mainstay of treatment, PCI. So when should be the PCI being done? So the PCI, the indications. Indications. In cases of a non-escalation MI or unstable angina, the mainstay of treatment is a standard conservative treatment we do. That means we give the three treatment option to the patient. We observe the patient, and if patient is stable, we can discharge. But when should the PCI be done? That depend on the risk of the patient. Whether patient is a high risk or intermediate risk or a very high risk. So what should be the PCI options there? So the indication is number one indication, PCI should be done immediately. Immediate PCI. Immediate PCI means it should be done within 2 hours. So it is done in cases of a very high risk patients. Very high risk patients. So the examples of the very high risk patients are hemodynamically unstable patient, or patient is in cardiogenic shock. If refractory angina, despite the medical treatment, the patient has got chest pain continuously. If there is a mechanical complication of MI, mechanical complication of MI like MR, acute MR for an example, then life-threatening arrhythmias, or patient is having heart failure, acute heart failure. So these are the 5 indications to do a immediate PCI. Now the second option is early PCI. That means कि within 24 hours. Early PCI within 24 hours. This is being done in patients of the high risk patients. So these high risk patients are the patient who have got a dynamic ST changes, means ki the changes are continuously happening, as well as when there is a increase or a fall in troponin levels, or a TIMI score, which is for acute prognosis, TIMI score more than 4, or a GRACE score more than 140. While what is a GRACE score? All these scoring, again I will put a PDF in your notes section along with the novel cardiac markers in your PDF I will put. Number third is a delayed PCI. That means it can be done 25 to 75 hours later also. And the indications of a delayed PCI are those patients who are having a intermediate risk. So it is for the patients with intermediate risk. Now, what makes the patient as having a intermediate risk where the delayed PCI is indicated? Those patients of diabetes or eGFR of less than 60, patient having a prior CABG, or a patient of prior PCI months. Ejection fraction less than 40%. TIMI score, TIMI score 2 to 3, or GRACE score 109 to 140. So any one of these indication will make the patient as a intermediate risk for the delayed PCI, for the delayed PCI. So this is the management point of the patient of a non-ST elevation MI and unstable angina. So this was about this lecture for today. That is the treatment, mainly the management of a angina, unstable angina patient and a non-escalation MI patient. So with this, we finish with the today's class, and the notes which I told you will be uploaded in your section soon.